Hi guys, we are opening a great subject called hyponatremia. By definition, hyponatremia, hypo-low natrium or sodium, and emia blood, so low blood count or level of the sodium. From the introduction part, hyponatremia commonly exists in concert with hypoosmolality when water retention or water intake exceeds renal excretion. And hyponatremia exists in approximately 50% of the hospitalized patients in the setting of increasing vasopressin release, which is a hormone responsible for absorption of water at the renal tubules. In the outpatient setting, hyponatremia is more likely to be a result of chronic disease, and in heart failure has been shown to be an independent predictor of 30 days and 1 year mortality. What are signs and symptoms of hyponatremia? They depend on the rate at which hyponatremia has developed and are less pronounced in chronic disease and more pronounced, of course, in acute cases. So, in addition, younger patients appear to tolerate a decrease in serum sodium better than elderly patients or with chronic diseases. So, anorexia, nausea, general malaise may occur early, but central nervous system signs and symptoms predominate later in the course and in acutely deteriorating cases of hyponatremia. The associated osmolar gradient allows water to move into brain cells, which result in cerebral edema. Edema is very important, and of course, increased intracranial pressure. Brain cells may compensate over time by lowering intracellular osmolality by movement of potassium and organic solutes out of the brain. But this reduces water movement into the intracellular space, and adaptive mechanisms can fail or hyponatremia progressing. So central nervous dysfunction may manifest as a change in sensorium and leading to seizure, or coma, brain herniation, and even death. I have a new slide with possible causes of hyponatremia. I classified in three main like low intake of sodium. It means from the diet you are eating food with low concentration of the sodium. Loss of the sodium through the many ways like nephropathy, like vomiting or diarrhea through the gastrointestinal tract. Delusional effect, one of them is where glucose is high or any of the solution which attract, this is a vessel, and solution which attract water inside of the vessel. And of course, sodium and water which is attracted into the bloodstream will develop a delusional hyponatremia. Hypotonic hyponatremia, and we have this great table, and it is by clarifying every of the moment like hypovolemia, eovolemia, and hypervolemia. Hypovolemia with the following signs, like decreasing skin turgor, flat neck veins, dry mucous membranes, hypotension, tachycardia compensatory, and oliguria or decreased urine output. So we are orienting on a sodium or natrium in the urine. If it is high, it is renal loss by using diuretics or any of the nephropathy. When sodium is low, it is extra renal losses like vomiting, diarrhea, pancreatitis, and third space losses like losing in a in a peritoneal space or a pleural space or cavity formed. Euvolemia when everything is okay but is a salt restriction diet, or when high sodium in the urine, glucocorticoid deficiency, hypothyroidism, or syndrome of inappropriate antidiuretic hormone deficiency, where kidneys are not responsible to the hormone release or receptors are affected, and hypervolemia with peripheral edema ascites. So, acute renal failure or nephrotic syndrome cirrhosis. One of the big mnemonic for hyponatremia and edema are cirrhotic, nephrotic, and CHF. All of them are with low protein level in the blood. So remember, if congestive heart failure, renal failure, or hypovolemic states such as cirrhosis or nephrotic syndrome, patient will develop hypervolemic hyponatremia. How you treat this state of hyponatremia in patient? So you should be careful, as you cannot correlate or correct level too fast. First thing to do is to withholding free water intake, giving loop diuretics but giving in the same time, for example, isotonic solution, or start with hypertonic saline like 3% sodium chloride. But you should be careful and make checking, make some check-in of the blood level of the sodium, and you should be careful about this, like giving 1 to 1.5 milliequivalent per liter per hour for patient, or a maximum increase of 12 milliequivalents per liter. For example, a normal range of the sodium in the blood is from 135 to 145, and hyponatremia means lower than this number, but a severe hyponatremia means lower than 120 milliequivalents per liter, and it provoke a lot of signs like central nervous system affection. And in this case, you can give hypertonic saline by 3% of sodium chloride. And you can increase in a 24-hour only by 12 milliequivalents per liter. For example, if you have 110, if it is possible even, milliequivalents per liter of sodium, so you are giving hypertonic saline and increasing in 24 hour by 12 milliequivalents per liter maximum. So you can increase it to 120 in the first day, and after you are giving 130 and so ahead. If you are giving too fast hypertonic saline or correcting the level, you can develop demyelination, pontine demyelination of the cerebellum, and some grave electrolyte disturbances. Hope this lecture is useful for you. If yes, you can follow and subscribe. Have a good time, guys.